Hi, my name is Bryan Schatmeyer, and I'm a senior at Valley Forge High School. I'm part of the science internship program at the Cleveland Clinic, and my project is disease control after spinal radiosurgery for metastatic prostate cancer. Prostate cancer is the most common non-skin cancer among men. The disease is curable if diagnosed and treated early. The most common site of metastasis for prostate cancer is the bone. Here is a picture of normal prostate. Here is a picture of prostate cancer. Stereotactic radiosurgery is a new treatment option for prostate cancer patients with metastases to the spine. SRS delivers only one large fraction of radiation rather than the conventional technique of giving multiple smaller fractions. Dosimetric calculations and treatment planning usually require 1 week. SRS treatment field size is a more conformal field size than that of conventional procedures. This allows only the cancerous vertebrae to be treated. The benefit of this is minimizing the effects of radiation on non-cancerous areas. As one can see down here, the purple area is the tumor, and the conformal yellow lines around it are the treatment field size. SRS treatment is done using the Novalis treatment machine. The patient lies down on a treatment table wearing a mask that contains infrared balls. These infrared balls match the target tumor with the radiation dose that is prescribed. Then the machine rotates and delivers the radiation. Conventional external beam therapy delivers multiple fractions of smaller doses of radiation. The treatment field size of EBRT covers more area of the spine, often including adjacent non-cancerous vertebrae. Although SRS takes a week to plan, the EBRT is normally done in a few hours. As one can see here on the picture, the field treatment size of EBRT is much more broad than that of SRS. It has been suggested that multifraction radiotherapy does not produce favorable outcomes in terms of disease control. It is believed that a single high dose of radiation will improve these rates. We hypothesize that stereotactic radiosurgery will have equal or improved disease control for metastatic prostate cancer patients. Normally, 3 to 4 months after conventional EBRT, approximately 1/3 of patients will have disease progression, a third will be stable, and a third will improve. We suspect that stereotactic radiosurgery will have less than a third who have disease progression. To solve our hypothesis, we reviewed the treatment records of 26 patients with prostate cancer who received 41 treatments with SRS for spinal metastases. The medical databases for EPIC and Mosaic provided access to the patient's medical history, which included prior medical conditions. Other components of the patient's medical history noted had been prescribed radiation dose, stage of cancer, the Charlson score, which had shown how many prior ailments the patient had had, the Karnofsky performance status, which had rated their efficiency of living, 0 being dead to 100 being perfectly normal. Other components noted were prostate-specific antigen and family history of prostate cancer. As one can see at the bottom here, the green is the tumor, and the lines around it are the isodose 50, the 50% isodose line. In the middle of the tumor is the isocenter. These margins were measured using MRI scans and CT scans. Tumor status was defined as disease progression, stable disease, or response. Cox proportional hazards regression was used to assess whether any patient or treatment characteristics were associated with disease progression. Here are some descriptive statistics for the prostate cancer patients. The median age for the treatment had been 66 years old. The pretreatment KPS score had been 80, which was fairly efficient for the patient. The imaging follow-up time had been 4.3 months on average. Some more descriptive statistics about the prostate cancer patients had been that 73% of them had epidural extension, so the tumor had moved into the epidural space on the spine. Also, 76% had prior external beam radiation therapy. Also, 63% did not have presence of non-spinal metastases. The results for progression-free survival had been that at 3 months, 80% of patients had progression-free. At 6 months, 58% had been progression-free. For the imaging results after stereotactic radiosurgery, it was shown that after 1 month, 23% had progression, while 77% had progression. From the date of last follow-up, which had been a median average of 4.3 months, 36% had progression, and 64% were either stable or responded. The Cox proportional hazard regression for progression had shown if there was any association for the patient characteristics or the treatment characteristics. It was shown that not all the characteristics, such as diffuse or multiple levels for single levels, had any association with progression. Also, epidural extension had no association with progression. But the margins from the isocenter to the 50% isodose line had approached significance at a p-value of 0.0661, needing a p-value of 0.05 to be significant. It is believed that with a larger study, the p-value would have been below 0.05 and been significant. We conclude that at 1 month post-SRS, approximately 3/4 of all patients were stable or had an improvement in their disease. 3 months post-SRS, 80% of patients were progression-free. This compares favorably with the expected rates following EBRT. Other findings had been that multi-level and diffuse spinal disease did not have a worse outcome with respect to disease progression when compared to single-level disease. Also, epidural extension of disease was not associated with a higher risk of disease progression. The margin size from the isocenter to the 50% isodose line was almost significantly associated with disease progression, having a p-value of 0.0661. This suggests that one should be aware of the minimal margins when planning SRS to ensure that all metastatic disease is treated. Some recommendations had been that even though SRS appears to have a slight improvement in disease control, precision and care must be used when planning the treatment margins, or else some disease may not receive treatment. Here are some references. And special thanks to Drs. Jay Sitsky, Chandana Reddy, Dr. Tufik Jamil, Dr. Samuel Chow, Dr. Liliana Angelov, and to the Office of Civic Education Initiatives. And thank you.